Welcome to our Parkinson Support Group of Sonoma County monthly meeting. This month, we are honored to have Dr. Pravin Khemani speak about autonomic dysfunction in Parkinson's disease. He will give us a presentation on autonomic dysfunction. Dr. Khemani is the medical director of the Movement Disorders Program with the Swedish Neuroscience Institute in Seattle. His philosophy of care for movement disorders is to adopt a multidisciplinary approach and closely collaborate with the patient, family, and other caregivers. He is the author of numerous publications on Parkinson's disease and is an investigator on several clinical trials. Welcome, Dr. Khemani. We're really grateful to have you this month.
Thank you. It's really an honor to be here and to interact with you and learn about autonomic dysfunction in Parkinson's disease. So this is a portion of my talk, my larger talk on non-motor symptoms in Parkinson's disease, but we'll focus primarily on autonomic dysfunction in Parkinson's disease. Today, maybe another day in the future, you can have me back and we can talk about other non-motor symptoms in Parkinson's disease. So this is the philosophy of care that I try to adhere to, which is the patient and their caregivers and family are usually the center of the treatment paradigm, which involves the neurologist closely collaborating with other specialists, including the primary care physician, which means that we have to continue to raise health literacy in Parkinson's disease, not only in the patient community, but also in the physician community. The objectives of today's talk are to very briefly review overall what non-motor symptoms of Parkinson's disease are, and then focus on the autonomic symptoms, review them, and review some treatment options for the autonomic symptoms in PD. Just a step back, we are going to just very briefly talk about the diagnosis of Parkinson's disease. Although non-motor symptoms form a huge component of the disease, the recognition of motor symptoms is what informs the diagnosis of Parkinson's disease. And there is this huge gap between the recognition of motor and non-motor symptoms that we are constantly trying to bridge, because as we know, non-motor symptoms can precede motor symptoms by years. But currently the diagnosis of Parkinson's disease is based on the recognition or identification of cardinal motor symptoms of Parkinson's disease, which must include bradykinesia or slowness of movement, and one of two of rest tremor, rigidity, or gait imbalance problems. That is, once we recognize those fundamental motor symptoms, then we apply a set of exclusion and supportive criteria, which include non-motor symptoms, in order to make the diagnosis of clinically established or clinically probable Parkinson's disease. Clinically probable Parkinson's disease is a higher level of certainty, diagnostic certainty, than clinically established. The absolute gold standard, we know, is to look at the brain post-mortem to identify Lewy bodies, alpha-synuclein protein, and the loss of neurons in certain areas of the brain, such as the brainstem and the basal ganglia. However, as I said earlier, non-motor symptoms in Parkinson's disease are a huge component and significantly impair quality of life. And they have been often neglected in terms of treatment and recognition. And this cartoon over here shows us the entire gamut of non-motor symptoms in Parkinson's disease, which are due to many reasons, but one of the prime concerns is autonomic dysfunction in Parkinson's disease. So if you had to list non-motor symptoms in Parkinson's disease, you generate a list of these symptoms. They include sleep dysfunction, psychiatric or mood problems, cognitive impairment, pain, fatigue, visual disturbance, and then the set of cardiovascular, gastrointestinal, genitourinary, and sexual symptoms basically are lumped together as the autonomic symptoms. However, if you really look at all of the other non-motor symptoms, there is a component of the autonomic nervous system that is involved in those other symptoms as well. So the autonomic nervous system is very widespread and truly is involved in the control of all bodily functions. We don't need to go through each and every aspect of the non-motor symptom for this particular talk, but the cartoon illustrates that the brain, joints, eyes, nose, mouth, heart, the stomach, intestine, bladder, and genitals can all be involved in Parkinson's disease. Just a very brief anatomic primer on the autonomic system. The autonomic system is divided into three components: sympathetic system, the parasympathetic system, and the myenteric plexus, or the system or network of nerves, which is quite complex, which controls the gut, which includes the stomach and the intestine. Sometimes we call this particular nervous system of the gut the brain of the gut, because it's under fairly autonomous control and works without a lot of interference from other areas of the body and the brain. The sympathetic system arises in the hypothalamus and the brainstem nuclei and other brain areas. They come together to form the sympathetic system, which is a network of neurons truly. Simplistically, as this cartoon shows you, neurons are nerve cells that come from the hypothalamus and other areas of the brain, descend down into the spinal cord, and synapse or basically communicate with cells in the thoracic and the lumbar area of the spinal cord. And then if you can see my cursor, these neurons or nerve cells then send out their tails or axons into the ganglionic chain. And there's one on each side, one on the right, one on the left, where the neurons communicate again with these ganglia or cells that then send out axons to basically control the various organs, including the eyes, the heart, the gut, and the sweat glands, the blood vessels, the bladder, and the sexual organs. There are two fundamental neurotransmitters that are involved in the autonomic nervous system, acetylcholine and norepinephrine. Acetylcholine is the neurotransmitter that allows neurons to communicate with each other, and norepinephrine is the neurotransmitter which actually elicits a response from these organ systems. That is in the sympathetic system. So the final neurotransmitter that basically makes these organs work and do what they're supposed to be doing is norepinephrine. In contrast,
Dr. Khemani, you have muted yourself somehow.
oops, is this better? I'm sorry.
Yes, yes.
Do I need to go back to the previous slide or?
No, you just muted yourself just a few sentences ago.
Okay,
We're
gotcha.
talking about norepinephrine.
Oh, okay, gotcha. So, okay, so let's come back to the slide, and I'll try not to mute myself again. I'll probably try to move this little bar out of the way. Okay, thank you for that. The parasympathetic nervous system arises from areas of the hypothalamus and the brainstem, but different areas than the sympathetic system. And when I say areas, I mean clusters of neurons or cells. And similarly, muted again. Sorry, I think it's the space bar that is muting me, so I'm not going to use that anymore. The parasympathetic nervous system basically sends its projections or neurons down to the cervical spinal cord and the sacrospinal cord. And these neurons basically come down, connect with the cells, and then, let's see over here, send out their axons or tails to innervate the organs that are similarly innervated by the sympathetic nervous system. So therefore, there is this push and pull between the sympathetic and the parasympathetic nervous system. The sympathetic nervous system is called the fight, flight, or fright system. It generates these responses, and the parasympathetic nervous system basically works to calm the body down and to regulate bodily functions when you're not in a heightened state of arousal. And it basically uses acetylcholine as the primary molecule to elicit responses from these various organs. And there are other neurotransmitters, including nitric oxide and vasoactive intestinal polypeptide. We don't talk about these very much, but they are important neurotransmitters that basically are responsible for the eyes and the heart and the gut and the bladder to work appropriately. This slide over here just demonstrates how complex the myenteric plexus is. I borrowed it, if you will, from a YouTube video by this extremely, articulate physician, Dr. Zach Murphy, who drew this entire schematic down from ingestion of a slice of pizza up here to how the brain and the gut work together in digestion. It's a very complex process, and there are obviously other organ systems, including the pancreas, the biliary system. They're all involved in the digestion of food, and truly their function in Parkinson's disease is not very well elaborated. We do believe that Parkinson's disease is primarily a disorder of nerve cells and not other tissues, but all other tissues and organ systems are regulated by nerve cells. So indirectly, it becomes a disorder of other organs as well. So we're not going to spend a lot of time on the myenteric plexus because I think there are books written on this, and we still don't have a fundamental understanding of how this system sort of works in order to regulate stomach and intestine function. This slide, which is taken from a helicopter of the Acadia National Forest, tells me that I got to switch gears now and talk about the actual topic over here, which is the autonomic dysfunction in Parkinson's disease. I've broken it down into 4 components: neurogenic orthostatic hypotension, constipation, bladder dysfunction, which is also called lower urinary tract symptoms by urologists. They use this acronym LUTS commonly in their notes, and then sexual dysfunction. Coming to the very first 2, I've lumped constipation and neurogenic orthostatic hypotension into one slide, although they are 2 very separate and distinct symptoms. Constipation in Parkinson's disease is primarily due to reduced motility of the stomach and the intestine. The gut basically is the entire gastrointestinal system, all the way from the mouth all the way down to the anal sphincter. But it's easy to remember gastric and gut separately. The symptoms of constipation are usually straining to have a bowel movement, decreased frequency of bowel movements to less than 3 bowel movements per week, a feeling of inadequate emptying of the bowels, stools being really hard, a feeling of obstruction, like you cannot pass stools, and using manual maneuvers to defecate, such as a digital manipulation of the anorectal area. And constipation is extremely common all over the world, and it has a myriad number of causes, and therefore it can be kind of complex to treat. But in Parkinson's disease, it is thought to be due to inadequate movement of the stomach and the gut. When you eat, the stomach has to digest food, then it has to empty food into the intestines, which then have to move. And the medical term for that is peristalsis, and through that movement, push food down the gut and then excrete the undigested waste. Neurogenic orthostatic hypotension is most commonly identified in Parkinson's disease as lightheadedness upon standing. But it is not uncommon for patients to come in complaining of a host of symptoms that could be due to neurogenic orthostatic hypotension. And they include headaches, fatigue, lack of physical endurance, sleepiness, sweating, neck pain, body aches, and muscle aches, primarily because blood is not perfusing the organs that are responsible for movement, like the skeletal muscle, for instance, and most importantly, the brain. When there isn't enough blood perfusing or going up to the brain, you feel lightheaded, because the brain is extremely dependent on a regular blood supply. So what happens in Parkinson's disease is, because of a dysfunction of the autonomic system, which is responsible for constricting arteries when you stand, there is a drop in blood pressure and the heart rate does not increase. The heart rate does not increase because the nerves that regulate the heart degenerate in Parkinson's disease. Typically in someone who is dehydrated, like soldiers, etc., who are standing out in the sun and who faint, there is a compensatory increase in heart rate. So the heart is trying to pump a lot of blood in order to make up for the lack of blood volume, because blood is pooling in the lower extremities. But in Parkinson's disease, that does not happen. So people with Parkinson's disease are even more prone to fainting than people without Parkinson's disease. Technically, neurogenic orthostatic hypotension is defined by at least a 15 millimeter drop in systolic blood pressure, which is the top number, or at least a 10 millimeter drop in the diastolic blood pressure, which is the bottom number, without a compensatory increase in heart rate of at least 15 beats per minute. And that occurs after 3 minutes of standing. That's technical, but in real life, you don't have to stand for 3 minutes in order to feel lightheaded. There are plenty of people who say, as soon as I stand up, very suddenly, I get a rush and I feel like I'm about to faint. But this is sort of the technical definition that is used in the laboratories to identify neurogenic orthostatic hypotension. All right. This is, I think, this picture is I think it's quite remarkable. This picture illustrates gastroparesis, which is a decrease in movement of the stomach. And what this picture is showing is this pill of carbidopa levodopa that is trapped in the stomach hours after taking it. So not only does a decreased movement of the stomach and the gut cause problems with constipation and digestion, but it can also cause problems with medication absorption, because if your medicine is stuck in the stomach and it doesn't get to the jejunum, or the portion of the small intestine where it is absorbed, then you don't turn on. And we know about on and off symptoms. So this is another issue, is inadequate medication absorption due to a lack of motility of the gut. But in terms of constipation, when we are evaluating someone with constipation, Whether you have Parkinson's disease or not, you have to take stock of many other things and ensure that there is not a general medical condition such as H. pylori infections, the bacteria that infects the gut, medications such as beta blockers and antidepressants, depressants, and even carbidopa, levodopa can slow the gut down. There can be structural lesions or adhesions if you've had prior abdominal surgery that can cause decreased gastric and gut motility. And then there are other disorders such as Parkinson's disease, diabetes, which can slow down the gut. In addition to Parkinson's disease, there's celiac disease, which is a malabsorption syndrome. All of this can coexist with Parkinson's disease, but all of these have different treatment strategies. So a comprehensive view of constipation is important in Parkinson's disease. However, the most common reason for Parkinson's disease, constipation and Parkinson's disease, is a dysfunction of the myenteric plexus. It's a nervous system issue. And then there is also degeneration of nerve cells or nuclei in the brainstem. One of those is the vagal nerve nucleus. The vagus nerve is the longest cranial nerve in the body, and it controls heart function in terms of heart rate and gastric and intestinal motility. How do you treat constipation and Parkinson's disease? It's very important to talk to your primary care doctor and get a general medical examination first to ensure that there isn't any other intervening cause of constipation. Diet should be modified with increased insoluble fiber. Hydration is absolutely critical. And then if with these general measures, there is not an improvement, over-the-counter fiber supplements, bulkers, osmotics, and prokinetics can be used. Now, prokinetics are not usually available over the counter. Senna may be considered to be a prokinetic, and Dulcolax, which increase the peristaltic movement. But one of the prokinetics that is given by physicians in people who've had abdominal surgery or gut surgery is metoclopramide in the hospital. This is an absolute no-no in people with Parkinson's disease. Do not take it if you're given it. You need to have a big warning on your medical chart. Do not take it because this can severely, this can make symptoms of Parkinson's quite severe. So this is a big no-no. So we are left with a couple, 2, 3 options. Polyethylene glycol or Miralax is one that can help with constipation. And then probiotics and prebiotics have been used to improve constipation, and there have been research trials that have shown that. Last but not the least, if despite all of these measures, constipation, bloating, and dyspepsia are common, then lubiprostone is a prescription medication that you can take to improve constipation and Parkinson's disease, and it has actually been studied to improve gut motility. There are other laxatives that can also be taken, and truly, it really depends on what works for you. Something that works for one person really may not work for someone else. And this is basically a trial and error sort of a situation to basically treat constipation and Parkinson's disease. Switching to neurogenic orthostatic hypotension or lightheadedness upon standing, this schematic shows you the treatment paradigm for NOH. However, before you treat NOH, it is important to identify it. And in order to identify NOH, which is lightheadedness upon standing, is it due to neurogenic orthostatic hypotension? One must measure blood pressures, and they need to be done in a certain way. What I do in my clinic is a 7-day blood pressure diary. We measure the blood pressure and heart rate in bed first thing in the morning in the laying down state, then have the patient stand up with assistance for about 3 minutes. and then measure the blood pressure and heart rate, and you chart these readings for about a week, and then you share it with your doctor to see if there is a drop in blood pressure when you're standing compared to when you're laying down. And here is a sample blood pressure diary that I give my patients, and they jot down readings in these columns and send them to me. If you've identified neurogenic orthostatic hypotension and you see it's present, the easiest and the lowest common denominator is to look at the medications. All medications that are used in the treatment of Parkinson's disease can potentially worsen lightheadedness upon standing, but you cannot stop medications that are given to you for treatment of Parkinson's disease, because that's obvious, you can't do that. But there are other medications given to people, such as high blood pressure medications, anticholinergics that are responsible for to treat bladder spasms, antidepressants, etc., that can worsen orthostatic hypotension. So a good medication review with the primary care doctor is really important to determine what medications can be eliminated or what doses can be reduced to mitigate orthostatic hypotension. And that arrow basically points to that. If despite modification of the medication regimen, orthostatic hypotension persists, then you want to take some non-pharmacological measures. Increase your fluid intake for sure, increase your salt intake if you don't have congestive heart failure or any other disease that precludes you to increase salt. Compression stockings are very difficult to wear. They're hot, they're sticky, but sometimes they might be necessary, and these have to go thigh high. The typical compression stockings that go knee high are not very effective in treatment of NOH. Abdominal binders, interestingly, have proven to be very effective. The way an abdominal binder works is it basically acts as a cinch. You put it around your lower abdominal area, and you only wear it when you are sitting up or standing up and walking about, not when you're laying down. What an abdominal binder does is uses mechanical force that pushes blood that is pooling in the gastrointestinal circulation, or the splanchnic circulation as we call it, and forces blood up into the aorta, into the heart, and then up into the brain. And in fact, that's how compression stockings work. They're forcing blood up. They're acting as a mechanical pump to force blood up into the brain and prevent its pooling in the legs and the abdominal circulation. And then in physical therapy, there are lots of exercises that can be learned, such as crossing your legs and moving your ankles and your feet and keeping them in constant motion, not unlike you do on a long plane flight, to prevent blood clots in your feet. We are using basically the skeletal, the mechanical pump of the body to force blood up into the heart and then into the brain. Despite all of these measures, one does not feel that their lightheadedness is adequately treated. And if indeed blood pressure continues to fall when you stand up, there are pharmacological measures that we use. And in this box over here are listed medications that we use in our clinic to increase blood pressure, with the understanding that the blood pressure increases in all positions, sitting, standing, and laying down. So you have to be a little careful with these medications. Droxidopa is boxed over here because it's the only FDA-approved medication for treatment of neurogenic orthostatic hypotension in Parkinson's disease. However, fludrocortisone and midodrine and pyridostigmine have been used, and we use it very regularly in people because droxidopa might be difficult to get due to insurance concerns. Sometimes when neurogenic orthostatic hypotension is quite severe, we may need to use a combination of these medications. Here, this particular slide shows you a very important phenomenon called supine hypertension, which is an increase in blood pressure when you lay down because the autonomic system is not working. Autonomic dysfunction causes both neurogenic orthostatic hypotension as well as supine hypertension. And it is critical to raise the head of your bed by 30 degrees or at least 9 inches, because you don't want a rush of blood into your brain. It can cause strokes and hemorrhages, etc. And so therefore, if you raise the head up a little bit, you can protect your brain from supine hypertension. In Parkinson's disease, both coexist. So even when you're not measuring your blood pressure when you're laying down, supine hypertension is quite common. So before you initiate medications like droxidopa, you must always raise the head of your bed. And putting extra pillows and wedges is not known to be very effective. You actually have to sort of raise the entire head of the bed up in order to treat supine hypertension, which can be quite a chore because you need razors for the head of your bed. Droxidopa is used for neurogenic orthostatic hypotension, and you can take up to 600 milligrams 3 times a day. You have to be careful because it can worsen supine hypertension and raise blood pressure. So if you're having headache or nausea or dizziness or nosebleeds, etc., please alert your doctor, because it could be because your blood pressure is actually going up much higher than it should. And we talked about midodrine and fludrocortisone briefly. But if someone has a pacemaker or atrial fibrillation or is taking blood thinners, is diabetic, and has other complex diseases that can also affect the autonomic nervous system and cause blood pressure fluctuations, it is very important to see a cardiologist. The neurologist and the cardiologist need to work together to ensure that the blood pressure is neither too high nor it is too low. There are now autonomic experts. Autonomic neurology is a branch of neurology that has come into its own, and it's always good to see an autonomic expert if you have unmitigated neurogenic orthostatic hypotension or supine hypertension despite effective treatment strategies. And I've done that in the past, but there are not too many of these specialists that are available. Switching gears to bladder dysfunction or lower urinary tract symptoms, or LUTS. This is primarily due to bladder hyperreflexia or bladder spasms, also called neurogenic bladder. This particular LUTS results in frequent urination at night, also called nocturia, and increased frequency and urgency during the day. Frank urinary retention is not common in Parkinson's disease. So if someone tells me that they've been retaining urine in the first 3 or 4 years of diagnosis of Parkinsonism, that is a huge red flag for another disease called multiple system atrophy that can really resemble Parkinson's disease. Whenever someone complains of difficulty with urination or frequency and urgency, I always tell them to visit a urologist, and particularly in men, to ensure that the prostate is not enlarged or there isn't another issue with plumbing. Urologists commonly do cystoscopy or urodynamic study to identify the cause of LUTS, especially if the prostate is not involved. And this is a very important test that tells us if there is indeed neurogenic bladder or neurological cause for bladder dysfunction. Once a neurogenic bladder has been identified and it is persistent, it is important to treat it because it can significantly impair quality of life. The most common class of medications that are used to treat bladder dysfunction include anticholinergics. Unfortunately, they're cheap, they're readily available, they're very effective, but in Parkinson's disease, they can do a number on the patient because they can cause psychosis, hallucination, worsened constipation. So it's best to try to avoid these medications if possible. The other 2 medications, sulfenacin and mirabegron, have been used very effectively in people with Parkinson's disease to treat neurogenic bladder. So if you can get these 2, that would be ideal. Then there are non-pharmacological ways of treating LUTs, particularly if frequent urination at night is an issue. You might want to restrict fluid intake for at least a few hours before bedtime. That's a commonsensical measure that might prevent you from getting up several times during the night to go urinate. And then there are physical therapists and occupational therapists that are actually dedicated to improving LUTs. And they're trained in genitourinary symptoms. Kegel exercises have been very effective in a small number of people. And then, of course, if despite all of these, there continues to be incontinence, then urinary garments, etc., are suggested for a neurogenic bladder. I haven't put down here botulinum toxin treatment. It has been used in people with Parkinson's disease, but it's accompanied by its own issues, such as a weak bladder and incontinence. So it's used and it's presented to people, but I've seen more problems than it solves. And then there are bladder and sacral stimulators that are more invasive that have been used to treat neurogenic bladder, but the literature is kind of mixed on their efficacy. How about sexual dysfunction? Very common in Parkinson's disease. At least 75% of men and women report sexual dysfunction at some point in their life in Parkinson's disease. In men, the most common symptoms are erectile dysfunction, problems with ejaculation and anorgasmia. In women, it's vaginal dryness, decreased libido, and anorgasmia. These are problems that are quite common in the community, even when one does not have Parkinson's disease, but they are orders of magnitude more common in Parkinson's disease due to autonomic dysfunction. There is a class of medications called phosphodiesterase 5 inhibitors, very commonly used in the general population, recognized by their trade names like Viagra. But the problem with these medications is they expand blood vessels, and hence they can worsen orthostatic hypotension. And I've had plenty of people with Parkinson's disease who have told me they feel extremely lightheaded after taking these medications. So one needs to be really careful with these medications. There is a whole different class of medications now, a newer generation of medications that don't cause as much orthostatic hypotension. So when you're talking to the urologist, it's important to remind them, hey, due to my autonomic dysfunction and Parkinson's disease, kindly prescribe medications to me that won't cause lightheadedness, because the urologist might not be aware of it. So you just have to advocate for yourself. A medication review is important when sexual dysfunction is a concern, because there are plenty of medications that are given for other reasons, such as heart dysfunction, diabetes, antidepressants that can cause sexual dysfunction. You cannot stop the medication suddenly. Please don't do that, but take stock of these medications to see if some can be eliminated under the guidance of your primary doctor or your prescribing physician, or the doses can be reduced. And depression and anxiety are very common causes of sexual dysfunction with or without Parkinson's disease, and they're highly treatable. So, definitely get that treated while being vigilant about the side effects of antidepressants such as Zoloft, Paxil. Some of these medications can compound sexual dysfunction. So you may be robbing Peter to pay Paul. So you have to be a little careful with these medications. And then I always send people to the urologist to make sure that the plumbing is okay when sexual dysfunction is an issue. And I think that is my last slide. The next slide is on non-motor symptoms, but maybe we can talk about this at another time. So I'm going to stop sharing and leave some time for questions. Thank you for your attention. Appreciate it.
There was a request for I think the name of the medication that you suggested avoiding.
Oh,
I
yes.
think it's the antiemetic.
Yes, metoclopramide or Reglan. That's a medication that one shouldn't use in Parkinson's disease. Actually, there's a whole host of medications one shouldn't use in Parkinson's disease. They're called D2 blockers. They're used for psychosis. And one needs to be very careful to not take these medications because these medications can worsen Parkinson's disease significantly. There are a few questions in the chat section, so I'll be happy to go down these. Jerry asks, can you please address atypical Parkinsonism? Sure. Again, a very vast topic because atypical Parkinsonism includes Lewy body dementia, corticobasal degeneration, multiple system atrophy, progressive supranuclear palsy. And I'll be happy to come back and talk about these, but they are probably not germane to autonomic dysfunction except Lewy body dementia, which is very important to recognize that diffuse Lewy body disease or Lewy body dementia can involve a lot of autonomic dysfunction. It can look very much like Parkinson's disease, but the hallmark feature of Lewy body dementia is dementia. The other disease that can present with significant autonomic dysfunction is multiple system atrophy. In fact, autonomic dysfunction is one of the criterions for diagnosing multiple system atrophy, and it occurs much, much earlier in the course of the disease than it does in Parkinson's disease. Thermodysregulation in this population is very common, and we do believe thermodysregulation is due to the dysregulation of the hypothalamus, as well as other peripheral components. Interestingly, I became interested in the hypothalamus in Parkinson's disease much early on, and I tried to do a lot of reading, and there isn't a lot of material on the hypothalamus in Parkinson's disease. I really think it's an area that should be studied. We talk about lower level brain centers such as brainstem and other neurons, but we don't talk a lot about the direct dysfunction of hypothalamus in Parkinson's disease. And I do suspect that there is dysfunction hypothalamus. And it's not just been studied, and thermodysregulation, which is an intolerance of heat and cold, is very common in Parkinson's disease, and it is an autonomic symptom. And not much can be done about it, unfortunately, because there aren't medicines that go directly and affect the hypothalamus that can help with the thermodysregulation part. However, there are other conditions that can cause thermodysregulation as well, such as thyroid dysfunction. So if someone has thermodysregulation, I always tell them to make sure that they go to the primary doctor and make sure that the thyroid is working okay. And then there are other causes as well that one can troubleshoot partnering with the primary care doctor. Low blood pressure can cause a feeling of being extremely cold, so that needs to be addressed as well. What is more difficult is a feeling of constantly being hot and sweaty. That is much more difficult to address than feeling cold, because if you're cold, you can add on layers. But the hot and sweaty thing needs to be dealt with fans and other sort of devices. Lungs and breathing are autonomic. Yes, the center for breathing is in the medulla of the brainstem, and it does not require brain control or cognitive control. So I have a question about muscle memory. I notice a lack thereof in taking dance lessons. That's a complex question. I don't think it's got to do anything with autonomic dysfunction. There are certain areas of the brain that seem to not work well in Parkinson's disease, and they've got to do with automatic movements, and walking, for instance. Walking becomes problematic in Parkinson's disease, and one needs to pay attention and concentration to it, because the wiring that allows us to basically be in locomotion or walk with, erect with 2 feet on the ground is compromised in Parkinson's disease. This ability to be a bipedal or, walk on 2 legs, which is very unique to the human primate, that seems to be dysfunctional in Parkinson's disease. As far as muscle memory goes, I'm not entirely sure about that aspect, but it is also true that continuous training helps with these movements, including walking and dancing, etc.
So you're saying,
I'm sorry?
so for instance, the fact that you never forget how to ride a bicycle is subconscious memory of some sort, but not part of the autonomic system.
That is true. The autonomic system does not mean automatic. The autonomic system is automatic, but the skeletal system, the basal ganglia, which are involved in Parkinson's disease, basically are involved in locomotion and mobility and some automatic movements that is separate from the autonomic system. Will this PowerPoint presentation be available in your archives? I suppose the answer is yes, because it's being
Yes,
recorded.
it will be. Yes, next month.
Okay. You mentioned acetylcholine. Can supplements or diet have an effect? Yes, they can. Although there is really no supplement for acetylcholine. The way acetylcholine works is it basically is a neurotransmitter that a neuron releases to communicate with another neuron. Eating acetylcholine does not necessarily improve the transmission between 2 neurons. So I'm not entirely sure if supplements and diet can improve the transmission of acetylcholine. Unfortunately, it's not that simple. Please discuss how to treat the shoulder pain and stiffness shown in one of the early cartoons. A very good question. Again, has not much to do with autonomic nervous system, but joint pain and musculoskeletal problems are very common in Parkinson's disease. If you go to the American Parkinson's Disease Association website, there is my recorded lecture on pain in Parkinson's disease, where I can come back and talk to you guys another time about pain in Parkinson's disease, but musculoskeletal and joint pain is quite common in Parkinson's disease. And it can develop fairly insidiously, and it may not respond to levodopa. And so therefore, as soon as you feel joint pain, decreasing range of motion, it is absolutely critical to undergo PT. Now, rotator cuff tears are also very common, particularly in active people such as tennis players, climbers, etc. So it is important that if there is actual mechanical injury, you got to see an orthopedic physician much early on. The longer you wait on joint problems, the more difficult they are to treat. So sometimes MRIs of the joint are needed to ensure that there is nothing fractured or broken or torn, and like a ligament or a muscle which needs, repair or surgical repair. So shoulder pain and stiffness can be from a myriad causes, but when nothing is fractured, nothing is broken or torn, then physical therapy should be ample to improve shoulder pain and stiffness. If there's arthritis, the treatment of that is different. If there is a lot of inflammation, then sports doctors and musculoskeletal doctors can inject that particular joint with anti-inflammatories and steroids. So when someone has shoulder pain and stiffness, with or without Parkinson's disease, you got to be fully evaluated to determine what is causing it. Due to straining, because of constipation, I have hernia, which has descended into the testicular sac. Now, that can be very complex. This is a surgical problem. You must absolutely go to a general surgeon to treat the hernia, because what is hernia? A hernia is basically a protrusion of one organ into another. The most common organ is the intestine. And if it protrudes into another organ like the testicular sac, it can become entrapped. It can be quite painful. So this is a reason to go to your primary care doctor, absolutely seek a surgical opinion to see if it can be treated before it gets too late. Not all hernias need to be treated surgically. And I'm not an expert in hernias, but just based on what I learned in medical school and in residency, after the surgeon evaluates you, they'll tell you whether a surgical treatment is necessary, whether a mesh needs to be put in to prevent the protrusion of the intestines into the testicular sac or the inguinal area. Of course, you have to treat the fundamental cause of it, which is the straining due to constipation, because that's why it happened. How do proton pump inhibitors affect medication absorption? If you use what is the best way to take along with extended release Cinemed? It seems that proton pump inhibitors decrease the amount of hydrochloric acid in the stomach, and achlorhydria, or the decrease in hydrochloric acid, occurs as we age. For the absorption of certain medications, including carbidopa, levodopa, an acidic milieu is important. And so therefore, if you're artificially decreasing the amount of hydrochloric acid in the stomach to decrease esophageal reflux disease, or GERD, they need to be used with prudence. And it is important to separate the proton pump inhibitors temporarily from the carbidopa, levodopa. At least don't take it at the same time. If there are other ways of treating GERD, such as fundoplication, some people have such severe GERD that surgical treatments are needed, then please exercise those. GERD can be treated by not eating spicy food, by not wearing clothes that are extremely tight, by eating earlier on. So non-pharmacological ways of treating GERD can be implemented before you take a proton pump inhibitor. Would eating an all-plant diet, which would have much more fiber than the standard American diet, lead to less constipation? And the answer is yes, because plants have magnitudes more insoluble fiber than animal fat does. However, at that point, it is very important to ensure that you're up to date on your vitamins. There's certain vitamins that are fat soluble, A, D, E, K, and then B12 and folate that are only found in dairy, eggs, and meat. So it is important to ensure that you're up on these vitamins when you are incorporating an all-plant diet in your food regimen. Have clinical trials yielded any positive results for Parkinson's disease? That's a very broad question. Yes, they have. All the drugs that we are taking right now are due to clinical trials, and these drugs are very positive. But if the question is in terms of slowing the disease down, stopping it, or reversing it, that's the holy grail. That's what we are looking for. And there are 2 or 3 clinical trials that seem to be more promising, and we are hoping that next year, the year after, we will get some results. The big thing in Parkinson's disease research is alpha-synuclein, how to remove the protein, how to stop it from spreading from cell to cell, thereby preventing the progression of the disease. There are about 3 trials that looked at this, and they were called the vaccination trials, but they didn't do very well, unfortunately. And that was probably due to that was probably due to the mechanism of delivery of the drug, or not enough medication being given to to the subject. So I think some of these trials will be repeated with higher doses of drugs and a better mechanism of delivery. What about breathing problems, both when not exercising and when beginning to exercise? Is this included in my topic? No, it's not, because breathing is such a preserved mechanism. It is so primal, it is so fundamental that shortness of breath is not very common in Parkinson's disease unless it's in the very, very advanced stages where the medulla is disintegrating. Typically, breathing problems occur in the on and off stages. And I haven't talked about this, but when someone is wearing off, they can get either really shallow breathing or they can start to hyperventilate. And when someone is extremely dyskinetic, they can hyperventilate as well. And so therefore, by modulating the carbidopa, levodopa, or the medications, one can try to mitigate the abnormal breathing that can occur in Parkinson's disease. The other causes of breathing, and we haven't talked about sleep, include obstructive sleep apnea. And this is particularly at night, which is quite common in the general population and also quite common in Parkinson's disease. That's the end of the questions in the chat section. Do y'all have any other questions you want to ask before?
Actually, there are more questions in the chat section.
There are?
Yes, if you could go down further.
I'm all the way down.
Has anyone been studying the role of neuroreceptors in Parkinson's?
One more question popped up. Neuroreceptors, especially when plenty of dopamine is available. I think you're talking about the dopamine 1 and dopamine 2 receptors. Yes, there has been a lot of study and ongoing, particularly in the dopamine 2 receptors. But the dopamine 1 receptors are also being studied. It is very difficult to target these receptors because of the inability of medications to get to them. And both the dopamine 1 and dopamine 2 receptors basically are two parts of a seesaw. They have to be in balance in order for the motor function, for the motor system to work. But there, of course, there are other neuroreceptors. There are serotonin receptors. There is adrenaline, norepinephrine receptors, etc. These are not thought to be dysregulated primarily in Parkinson's disease. It's the nerves leading to these receptors that seem to be the problem rather than the receptors themselves. And on my chat, that was the last question.
I have a question that's, can you hear me?
Yes, I can.
I have a question about the name of the organization you work for. And I'm just curious about why it's called Swedish Health for Good and what the relationship is between Swedish health and what you do.
Oh, yeah. Okay. I work for a Providence Swedish Health Organization in Seattle, Washington. And it's called the Swedish Neuroscience Center because supposedly it was established by the Swedes or Norwegians about 100 and some years ago. Health for Good is its motto, but I'm an employee of the Swedish Neuroscience Institute here in Seattle.
Thank you.
You're welcome.
Well, thank you, Dr. Khemani, for your presentation. It was very informative.